Welcome to our latest session on Scientists Answer Your Questions, a series of free webinars that are sponsored by the participants in the Vitamin D Action Project at Grassroots Health. I'm Sharon McDonald, an epidemiologist here at Grassroots Health. Today we have with us Dr. Bruce Hollis, presenting information on the importance of daily vitamin D dosing and why our bodies need to maintain a steady amount of D3 to reduce the risk of many diseases like cancer. As many of you know, Dr. Hollis is a professor at the Medical University of South Carolina and has been a leading researcher in the field of vitamin D for many years. We receive many questions from our participants about vitamin D dosing. We are very excited to have Dr. Hollis join us today. So Dr. Hollis, it's all yours.
Thank you very much. This is a concept that's rather biochemical, but I've personally thought about this for a long time, and being involved in vitamin D biochemistry and in clinical trials and reading the literature of how all this fits together. And so if you look at clinical trials, which we'll do later in this talk, about people would run the same basic type of clinical trials but come up with different results. And why would that be? And we started thinking about this and concluded it's not only how vitamin D is in the body, but how it gets into the body and how the body handles it. So if we go to the first slide, vitamin D there's two functions of vitamin D in the two systems of function of vitamin D in the human body. One of them, if you're an endocrinologist or have been trained in medicine, the first one would be defined as an endocrine system. And that's the one that's been known forever. That's the one that basically controls the function of vitamin D in the skeleton. And since it's been around for a long time known, and all the studies basically in vitamin D until the last few years have been performed on the skeleton, it's what everybody goes by, no matter what studies of vitamin D, if they're studying, whether it be bone or infection or autoimmunity or cancer suppression or cardiac diseases, they all go by the systems that have been studied in bone, and we have come to the conclusion that that shouldn't be so. And again, vitamin D functions at two levels in the body. Okay, the endocrine, which primarily maintains calcium homeostasis, and involves a system called the megalin tubulin system for the endocytotic transfer of vitamin D into the kidney, say. And I know that sounds very technical, and when I get to the slide, I'll explain what that means. And also the next one here, vitamin D would function in an autocrine paracrine function, which involves a simple diffusion of vitamin D compounds into tissues and cells where they would perform that function directly without the endocrine function. So we'll go to the slide here, and it's going to take a while to get through this slide. So we have vitamin D right here, which is the compound which is made in your skin when you get sun exposed or when you get it orally from the diet. And then vitamin D goes into the circulation, and then many things happen to it. From the standpoint, we'll go through the endocrine system first because it's the one that deals with the bone maintain of calcium homeostasis. So what happens to vitamin D in those terms is the vitamin D goes into the liver, okay, where it's metabolized, and a hydroxyl group is put on to turn it into 25-hydroxy vitamin D. This is the prohormone. This compound, 25-hydroxy vitamin D, stays in the blood for a long time. If you look at vitamin D here and 25D, underneath I have T1/2. Those are referred to as half-lives. Drugs have or compounds have half-lives, which means how long they stay in the circulation before they disappear, okay? And the faster the half-life, the faster the compound appears and disappears into the blood very quickly. So if you look at vitamin D here, the half-life is about 24 hours. So any dose that you gave today would be in your blood would be half gone. It would be half of that amount remain in your blood 24 hours from now. If you go look at 25, the half-life is 3 weeks, which means if you give that dose, it basically stays in the blood for a long, long time, okay? And what controls this amount of staying in the blood, whether compared to vitamin D and 25D, is how it binds to a carrier protein called the vitamin D binding protein that exists in our circulation. And this protein specifically binds vitamin D and carries it around in the circulation. Now, that has benefits, but it also has drawbacks, because what it does is, as long as the 25 vitamin D or 25-hydroxyvitamin D are locked on that protein, okay, they don't have the ability to do anything in the body because they're held outside the cells. Okay, that becomes very important if we talk about the paracrine and autocrine or paracrine function, but again, we're talking about the endocrine function. And so what happens here is you have 25-hydroxyvitamin D now locked onto that protein. Well, it's so important in the maintenance of skeletal homeostasis that the human body has developed a specific way to actively transport the whole protein complex, 25D, and the vitamin D binding protein that it's on, directly say, here you see the green arrows, into the kidney, okay? Then what happens, that whole complex goes into the kidney by a specific receptor. It's a megalin. It's a big protein that basically grabs that whole complex and brings it into the kidney. And then what happens is it delivers it to the enzymes in the kidney, the 25D, which puts another hydroxyl group on where you now have 1,25-dihydroxyvitamin D. Now, in these cases, in an endocrine, the kidney shoots this compound back out into the blood, okay, because that's what endocrine means. It means it's made in the kidney and delivered to other sites. And in this particular case, the major site where this is delivered to, the 125 to act, is the intestine, where it tells the intestine, okay, absorb calcium. And it activates a system where it does. And if you look here at 125, the half-life of 125 is extraordinarily fast. It's 2 hours, which means that compound is basically going in and out of cells like mad. Okay, it goes in and does its function. The intestine is very sensitive to this. And so what happens in the endocrine system is it goes in, it initiates active transport of calcium and increases plasma calcium and maintains calcium homeostasis and bone health. Okay, so this is the system by which all the dosing studies have been done, and for skeleton. And the reason it works is because vitamin D is metabolized in the liver to the prohormone, which locks on this protein and can specifically get into the kidney by this specific mechanism. So it doesn't matter if it's on the protein. In fact, it needs to be on that protein to get in. And it's also interesting, you'll see another one here. And the placenta is another place where this takes place. And it's a lot to go in here now, but it's, why the vitamin D is taken into the placenta. There's probably a lot of reasons, but this megalin system of active transport of 25 and this protein into the placenta is another important mechanism. So now let's go back to the other one, which is the majority, okay, of systems in the body, how vitamin D is delivered, and that is by the red arrows, which is basically the amount of vitamin D that goes into these tissues, the parent compound when it's delivered, is through simple diffusion. It's not really locked onto the vitamin D binding protein very tightly, and that's the reason that it disappears from the circulation so fast. That's good and bad. Okay, it's bad from the standpoint because it has to be put in there every day, or this particular amount goes away very quickly. And that's a downside. The best example of this is the amount of vitamin D in human milk. If a lactating mother doesn't take her vitamin D every day, the amount of vitamin D in her milk is very low. The reason for it is the vitamin D has to be not attached to the protein or very poorly attached to diffuse into her milk, where 25-hydroxy vitamin D, the whole protein complex can't go over, and since it's all locked on this protein, it can't gain access to the milk. So you can have plenty of 25-hydroxy in your blood, a mother who's lactating, but it cannot get into her milk. And that is why during lactation you would have to have vitamin D every day, because it's the one that would simply diffuse into the milk, and then the infant drinks the milk and gets its vitamin D. So this whole concept not only pertains to milk, it also pertains to almost every function of vitamin D. And if you look at this diagram, we have vitamin D here, this big fat arrow, meaning a lot of passive transfer, diffusion, into cells like breast cells, colon, skin, brain, every other place. You look at these little skinny arrows here, 25-hydroxy, because it's all locked on this protein, it can't get into these cells. These cells don't have this specific transport mechanism like the kidney does. And again, this system would be called the Paracrine. And what that means is, okay, vitamin D in this big fat cell goes into a breast cell, or a colon cell, or a prostate cell, or have prostate cancer. And the cell takes the vitamin D that's diffused in and grabs it, okay, and then sends it to enzymes, both a 25-hydroxylase and 1-hydroxylase within that same cell, and then activates it to the active form of vitamin D, and it acts within that cell to do whatever it's going to do, regulation of cell growth by many different mechanisms. But it stays in that cell. It doesn't get excreted back out and sent to other sites in the body, and that's why it's referred to as autocrine or paracrine, because it's not an endocrine fashion like over here where the kidney takes it in and then excretes it out and it goes to other sites in the body to act. And so what happens here, okay, in a quick, if you take a large dose of vitamin D, say once a week, if you do it every day, this amount of the amount of compound here stays pretty stable because you're inputting it every day. Now let's look at what would happen if you gave a dose once a week. This compound would come in, and then within a day it's dropping off very rapidly in the blood, and within a few days it's gone down to basically nothing. And so there's no compound here to diffuse into these cells to be activated. A lot of it has been transferred to this that stays in the blood a long time, but really cannot get into these cells. So it's like it's on the outside looking in, and the cell can't get it to use it. And so, and the worse it gets. So once a week is daily's best. You know, every other day is not as good. Once a week is even worse. Once a month is useless, okay? Not from a standpoint of bone diseases, because again, if you dose these large studies and they go this route by the endocrine, this compound stays in the blood a long time, and so you can get away with that once a week, once a month, you know, once every 3 months, and still maintain this compound for the bone part. But again, you're out of vitamin D in the blood, it's gone, and you don't have this part. And when you're looking at outcomes for infection, breast cancer, colon cancer, we feel that you have to have this adequate amount or the system is not complete. And again, this is all due, if you want more information on this, it's a lot of information for a layman to grab. You need to understand how vitamin D, 25-hydroxy, and 125 all bind to this carrier protein. It's called a vitamin D binding protein. They all bind to it with different, what they call affinities. The tighter the affinity, the longer it stays in. Vitamin D has not a very strong affinity for that protein. 125 is even worse. It's basically not even bound to the protein with any affinity, whereas this compound, 25D, is locked on there very tightly. It doesn't come off. It stays on there with high affinity, which why it stays in the blood for long periods of time. But again, it can't get into cells very well unless it has this system that will grab the whole complex out of the blood, like the kidney and the placenta, and there might be other ones, but these are the major ones. So let's go to the next slide here, and we'll look at the vitamin D dosing, clinical dosing trial. So again, there have been many trials done on daily dosing of vitamin D, weekly dosing, monthly dosing, quarterly dosing, and even a study or two on yearly dosing. They refer to this as the STOS therapy. If you really want to look at how vitamin D, I mean, it's the same as, to me, it's the same as taking your cholesterol medicine. Do you take that once a day? Do you take it once a week? You certainly don't take it once a month. And you absolutely don't take it on a quarterly basis or once a year. It would be, you could take a big dose and it would be absolutely of no use whatsoever. And we view vitamin D along the same lines as that. Again, you can get away with weekly doses, monthly doses, and even quarterly doses if you are looking at skeletal problems. But if you are looking at other problems such as cancer suppression, immune function, we feel that these doses, weekly dose, you know, you might get away with it in some, but these other doses, absolutely not. Monthly doses, quarterly doses, yearly dose. If you really want to have physiologic equivalence for all these studies, you would want to do a daily dose. So let's look at, we assembled this graph that I did last year, and these are different, the journals aren't listed in here, but the first author and the date of the study, you could probably search these out in PubMed, but this slide is in two parts. And the trials here are on the type of trial: pregnancy, lactation, there's cardiovascular. What I want to really show you, and then what the dosing was, and if it was a randomized clinical trial or an interventional trial, and if the results of those trials were positive or failed, okay? So let's go, and a lot of these are positive, okay? And you'll see they're positive trials based on what the investigators were looking for. If you go down here to this Martineau study in 2011, they were looking at infection in pulmonary tuberculosis in a randomized. Well, lo and behold, they were given 100,000 units of vitamin D in large bolus doses, and that study turned out to be negative. Okay, and if you go down, the most interesting to me are the infection parts. I'm not talking about skeletal studies here because they don't fit into this model. Skeletal studies have been used in all these. They're all pretty positive, except somebody did one where they gave 500,000 units once a year and said, well, you know, that study wasn't even effective against bone and caused injuries. Well, I mean, what do you expect given a drug once a year and expect to have it, you know, supposed to be okay for a whole year? It didn't work. So even skeletal has its limits about how infrequently you can give it. But look at these last three, and we'll go into the next slide. This Urashima, Carlos Camargo study, and this other study, Professor Bergman. This one really caught my attention. And the reason that the Bergman study caught my attention is they were looking at respiratory tract infections. It was an RCT, and they gave their vitamin D 4,000 units per day versus placebo for 1 year. This was in the British Medical Journal, I believe, and they got positive results, which means they had, you know, suppression of infection. You know, vitamin D showed positive effects towards suppressing infections. Let's go to the top of this slide. Okay, and look at these next two slides, or these next two studies. Actually, it's the Manesky-Holland study of 2012 and Murdoch study. Both of these studies were in really high-profile journals, like JAMA, and I think this was in Lancet. Okay, and it's amazing is that the high-profile journals, to me, like to publish failure studies, but they're not really interested in the positive ones. Although the Bergman study was in British Medical Journal of one of really high profile, but the Bergman study was basically the same as this Malansky-Holland trial and Murdoch trial. Okay, they were both looking at the same things. They were all randomized controlled trials. What was the difference? The difference was this: while Bergman gave 4,000 units of vitamin D every day, this first trial gave quarterly 100,000 units, and Murdoch gave monthly doses of vitamin D. Okay, and both of those studies failed. The only difference basically is the way the vitamin D was administered. And while if you're looking in all those studies, if you're looking for how it maintained circulating 25-hydroxy vitamin D, they all maintained it. Okay, because it has a long half-life. What would be a big difference in those studies would be what vitamin D would have been. In the Bergman study, again, we go back to the previous slide. In the Bergman study here, 4,000 units a day would have resulted not only in stable levels of 25 vitamin D, but also stable levels of vitamin D. Okay? Whereas in these studies right here, the quarterly would be absolutely a disaster. I mean, the vitamin D would be there for a couple of days and then it's gone, and there wouldn't be any more. And so it's totally gone. The monthly on these doses, most of it would probably disappear within a week, and then the last 3 weeks before the next dose, it would be basically non-existent. And so any function where vitamin D itself was trying to get into cells and do its thing is not going to happen. It would totally be dependent on 25 vitamin D, which is not there a whole lot to get into these cells. And so if we look down, again, there's a whole bunch of other studies, and whether they were positive or negative. This was the Women's Health on Cancer. It was daily, but they didn't give anything, so they wouldn't see any results. 400 units a day, you wouldn't see any results on anything except maybe some bone studies, but not for this one. And there's been other cancer studies in the LAPI study. The Trivedi study here was they gave a dose every quarter, 100,000 units for 1 year, and it was negative on cancer. And then if you look at some other dermatitis studies, they've all been fairly positive if they're given in a daily dose. So the bottom line is, if you want to see studies other than skeleton, okay, and you're looking for the best outcomes, you do not want to give these compounds on a infrequent basis. I know it's, you know, weekly doses or monthly doses is quote easier for compliance, but you might not get the outcome from the disease you want based on that. So what are the conclusions? Okay, 400 to 600 IU of vitamin D intake will prevent most skeletal abnormalities in an adult. Okay, well, why take a chance? Okay, I mean, again, from an endocrine standpoint, you could probably get by with that amount. But 400 to 600 IUs will do very little for paracrine. So if you're trying to prevent infections or cancers with that amount of vitamin D, it's not going to happen. Okay, you need to have a lot more. Vitamin D intakes of up to 10,000 IUs a day and circulating 25 levels up to 100 nanograms are normal in human physiology, and thus they should not be afraid and do not treat as poison. Finally, design vitamin D dosing regimes for clinical trials based on normal physiology and not convenience, which again is, if you're going to do a skeletal study, bone study, or calcium study, if you want to give it on an infrequent basis, you're probably okay doing that. If you want to, but don't use those, don't design a study that's designed for endocrine functions of vitamin D and try to apply it for paracrine endocrine function, which is most of the other functions that vitamin D would have. And that would conclude my lecture.
Thank you, Dr. Hollis, for your presentation. The information was so interesting, and I'm actually excited to hear some of the answers to questions we have about vitamin D dosing. And so let's take a look at the first one. Could you briefly reiterate the benefits of daily dosing compared to longer interval dosing?
Well, again, if you want to have everything in vitamin D from the parent compound to the, well, basically the parent compound to be stable in the circulation, you need to give it every day because it disappears so fast. And so that happens in daily dosing regimes where if you dose once a week or once a month or whatever beyond that, you will maintain 25-hydroxy at a level that you're shooting for, but the parent compound is gone. And so all the things I went through there in that slide would no longer be no longer in play, and we believe that that's a big problem in tissues that function on a paracrine and endocrine relationship rather than say the skeletal system, which functions on an endocrine regime.
Great, thank you. And so you briefly talked about this, but the possible consequences of having the larger fluctuations in the circulating vitamin D3 as a result of those higher doses at longer intervals. And so what are those consequences again, if you could just reiterate that for us?
You have say you give somebody 100,000 units on a given day, and then you just let it go, and then a month later you give them the same dose. But what happens is that the vitamin D goes way up, okay, for a period of 12 hours, and then rapidly, okay, decreases, and the 25-hydroxy will slowly inch its way up, okay? It'll keep on going up, but the vitamin D is come and gone, okay? So it's not there anymore. And while 25-hydroxy will rise and maintain for quite a period of time, weeks, okay, the vitamin D3 part, the parent compound, is gone, and again, the diffusion system by which it would go into other tissues is gone because it's not there anymore. And once it goes to wherever it's going, be it, it leaves the blood, goes into tissues, it doesn't come back. So it's not like the body will release it back and have high blood levels. It doesn't. It goes away and it's gone.
That makes sense. Thank you for that explanation. And so I also know you talked about breastfeeding mothers, but could you tell us again why, in particular, dosing intervals are important for breastfeeding mothers more than probably anyone else? Because the vitamin D, it's the vitamin D, okay? When you talk about vitamin D content in milk, if we talk about the vitamin D content in blood, we forever, and you guys at Grassroots and everybody, we measure the 25-hydroxy level, okay? That's what we consider the normal nutritional status marker. And that's fine, and that's as far as we know. But what happens in a nursing mother? Okay, you could have a nursing mother who would have 50 or 60 nanograms of 25-hydroxy, but haven't had any input of vitamin D for a couple of weeks. Okay, her vitamin D levels are basically zero, even though she has a lot of 25-hydroxy in her blood. The 25-hydroxy in her blood is not going into her milk, okay? The vitamin D is what's going in there, and if it's not there, it's not going in. So you could have a woman who has excellent 25-hydroxy if you looked, yet her infant would be getting no vitamin D because the 25-hydroxy isn't being transferred in the milk. It's the vitamin D that's going in. And so it's really important that breastfeeding mothers would take these amounts, we say 6,000 units per day. And if you do that, then there's plenty of vitamin D every single day going into the milk and other places. Great, thank you. And do you know if circulating vitamin D3 concentrations vary by race or ethnic group? Only if they're not getting enough. I mean, black people have
have less 25 and they're going to have, you know, the same less. I mean, the thing is, if you take a normal population of people who aren't taking substantial supplements and you look for vitamin D in their blood, you basically aren't going to find it because they're not taking enough. Unless you're taking a couple of thousand units a day by supplement, there's just not enough there to even see. So race, ethnic, by, you know, say if a person of color, a black person, took 6,000 units and the white person took 6,000 units, you wouldn't be able to tell who was who if you just looked at their blood.
That makes
Black sense. People by race are going to have less because they utilize the sun less, but you know, it's just a matter of how much is made by the skin or how much you take in by your diet. It's not a race thing other than that.
Okay, great. And so what dosing factors need to be considered when designing a study or reviewing its published results?
Well, you need to, you know, I've in fact, one of those studies that was in, it was Lancet. I reviewed it a couple of years ago, and the title of the study was Vitamin D. It was done on, I think it was done in Afghanistan. It was done they gave 100,000 units every 3 or 4 months. And they looked at the results and they said vitamin D is ineffective against infections. And I argued with the editors and the authors. I said, what you've shown is vitamin D given in a bolus fashion is ineffective at preventing infections. You haven't proven that vitamin D is ineffective at preventing infections. You've only proven the way that you've given it is ineffective. And then that study was done first and published, and then the Bergman study, which was on that chart, which was in the British Medical Journal, gave 4,000 units and saw quite good results. And I actually was in contact with him, and I said, what possessed you to do it on a daily basis? And he says, we just talked about it and thought that would be the best way to do it. So it was just by chance they did it on a daily basis. It's more of a pain to do it that way. But if you want to prove that vitamin D is or isn't successful at doing something, you really have to take into account the dosing. We know what's effective on skeleton. That's been done for decades. So we know that these bolus dosing, but just because it was effective on skeleton in those things, you can't assume that it's going to be effective on other things that are totally different systems.
Great, thank you. And so the next question is, and just to bounce off that last question, is what specific study outcomes are particularly affected by dosing that you were mentioning? Well,
I think any the cancer studies, autoimmune studies, infection studies, anything like that. Basically anything that's not to do with skeleton.
Gotcha. And so daily dosing seems to generate an issue with compliance. Can you share your thoughts about how compliance could possibly be addressed?
Yeah. Dog your patients. Yeah, which we do all the time. New technology administration, yeah, it'd be great if you could have steady release vitamin D patch or something into your blood where it would maintain it at a stable level. Okay, but I don't know that exists yet. I'm certain what you're talking about is like people who take testosterone, estrogen patches, or things like that deliver a steady state over a daily period. Sure, that'd be great. That would be great if it exists, but I don't know that exists yet.
Yeah, a new invention for a new era. We'll see what happens. And next, a recent pilot study by Priam-Beda et al. Found that an initial dose of 120,000 to 180,000 units was required to raise 25-OHD to above 20 nanograms per milliliter among a highly deficient population, and that maintenance doses are needed every 2 months. Again, can you tell us what they were missing by doing this?
It's a highly inefficient way, again, of, so if you, look, most bone issues related to vitamin D are probably cured at 20 nanograms. For sure that most of them are, that's the argument between the IOM and and some other data. But to be honest, most bone abnormalities in people are probably cured when levels are above 20. You know, if you want to make absolutely sure everything is okay, then it would probably should be above 30. And which is this isn't going to be the same for cancers or other things. I mean, so you're looking at, again, endocrine and paracrine and different systems. But by administering 120 to 180,000 all at one time, it's highly inefficient, okay, because the body is flooded with vitamin D initially in that first day or two, and then it's just thrown out. It's gone. So some of it sticks around, gets converted to 25, but it's a highly inefficient, wasteful process. The body doesn't handle it. It handles what it can, and then, for a long time it thought it was stored, but it's not. Okay, it's not stored. Bob Haney's, had done papers on large dosing studies and looked in adipose tissue after dosing happened, and it's just not there. So where it goes, who knows? It, bile through the intestinal tract, urinary tract, but it's gone.
Yeah, that makes sense. Thank you for that explanation. And finally, what serum 25-OHD concentration do you recommend for people to attain using daily dosages?
Again, we come back to, we look at 25D as basically a surrogate for how much vitamin D, but it's a rough one because, again, you could take vitamin D every day, and if you miss some days, your 25D is still going to be up there. If you take huge doses of vitamin D, 25D could be up there for a long time when D is gone itself. So in our own studies here to do with prostate cancer and dosing men who have prostate cancer for a year, I'm convinced that the results we see, okay, in these guys, we dose them 4,000 units every day. Their 25D levels get up to about 60 nanograms. It doesn't even matter where they start. At the end of the year, if they're in compliance, they're mostly at about 60. And we see dramatic changes in their prostate glands. Not only do we see less cancer, we see a lot of genomic changes. We see a lot of lipid changes in their membranes. And I'm pretty convinced that if say we used 25 hydroxy vitamin D and not use vitamin D, and in those patients got the 25 hydroxy vitamin D up to 50 nanograms and bypassed the vitamin D level, I don't think we're going to see the great results that we're seeing because we've bypassed vitamin D, and again, the 25D just isn't available to get in those tissues like vitamin D is itself. So I think we're using 25D as a surrogate. Certainly you have to have more vitamin D to have higher 25, but again, I think you need to have daily inputs or maintain circulating vitamin D to optimize the system as it developed in human physiology, where we used to be in the sun all the time, and certainly we had high vitamin D levels on a daily basis until maybe 10,000 years ago.
Thank you again, Dr. Hollis, for your presentation about vitamin D dosing. We have lots of people who are interested in knowing about dosing intervals. We appreciate you sharing your work with us today. And the bottom line is daily dosing is the most important way you can get your vitamin D. I also want to thank all the listeners for watching this Scientists Answer Your Questions video session. Let us know what questions you have for our scientists by visiting our website at www.grassrootshealth.net. On our website, you can also watch other Scientists Answer Your Questions videos on the Videos tab and find information about how to join the D Action Project.